You guys have an extra orange?
You don't? No, that's good.
Can we get another orange?
2 oranges? 1? Cool. Alright. Any problems with this question?
No.
Is it a fair question?
Yes.
Yes.
Try this question. How about this? Fair?
Yeah.
No?
Yes.
You said no.
Yes.
Fair? Someday you're going to say, no, that's not fair.
Yes.
Fair or not fair?
Fair.
Fair.
50-50, it's fair. That's a coin flip.
Cortical bone is hardest to move.
I saw study guides, that's what there's cortical bone.
Does somebody want to make a comment who missed the question? You can say a comment. What is going on this way right now?
My teeth are...
Somebody makes this question inappropriate? Somebody want to make an argument?
No, I just remember seeing cortical bone on the study guide. I don't remember seeing trabecular bone, so that's why.
Okay. So let's say like thumbs up or thumbs down for this question.
What is
Do you guys think it's okay or not good?
It's okay.
How many thumbs down are we getting?
Thumbs up, thumbs up.
How about this one?
That's better.
Heavy?
Wait, I didn't even remember to read it. Okay, it's fire. It's fire.
This one okay according to my notes?
Yes.
Yeah.
Yes.
5 feet? Okay. Everybody's good. Orion.
Yes.
That's an 82.
I might have missed.
Really? Yeah, same. I think it was in the notes though, right?
Yeah, it was in the-
It was, though. Alright.
Wow.
Is that what fair too?
I put 30.
Yeah.
So it's mostly a good quiz?
Yes.
Not a terrible. You guys are all still in the running for A's, right? I hope.
Well, each question's what, 3%?
2%.
2%.
Question is 2% of our grade.
You're great. Because I have 2 quizzes, 10 points each, and the final exam is 30. So there's 50 questions in the whole class. Okay, so
Let's start.
let's start.
Let's start.
Who is George?
Curious, George.
Curious. Curious. George of the Jungle. So who is George of the Jungle? You guys don't go that far back, do you? Anyhow.
Yeah.
Ow!
Brendan Fraser, right?
That's old.
That's pretty old, Brendan Fraser. He looks different now.
It's like when I was 7.
Yeah. Okay, so
Don't worry about it.
come on. Here we go. Okay, so today we're going to talk a bit about the ortho evaluation. Obviously, we're looking for strange-looking teeth, right? Mm-hmm. That's what we're doing, strange-looking faces.
Something strange, and maybe good. Who you gonna call?
Okay, well, maybe orthodontist, right? So I have a clip from the movie that I think is appropriate for this class.
Now stay close. Stay close. I know. Do exactly as I say. Get ready. Ready? Get
And she's not alone because I have 3 volunteers that are helping me out for this lecture today. So let's try to see who's. Okay, so let's go back to the lecture. Gotcha. Okay, so this is normal. This is what you guys probably do in dental hygiene, right? You come up with a patient interview, come up with a chief complaint somewhere in a clinical exam, measure all the pockets, whatever you guys do, and you come up with some kind of database and you have some diagnosis eventually, right? So, same thing we do in orthodontics. We're going to find out the patient's chief complaint, why they're there, why did they come into the office, do our whole complete clinical exam, and then we'll get records too, because the orthodontists are famous for records, right? We have study models, photographs. We document everything that we do exactly. So we do all that, records, a regular clinical exam, because we got to know about the joints, we got to know about the gums, we got to know everything about the patient before we get started, and before we come up with a individualized plan for the patient. So we do all this about as well as can be done. Study model photographs, intraoral, extraoral photographs, all kinds of radiographs. You know, you guys are familiar with this one, right? We had a whole lecture about that because it's kind of important how the teeth relate to the bone, how the teeth relate to the lips, and the facial type and things like that. So but we do a FMX just like any dentist. Well, maybe not any dentist, but many dentists do a FMX. In fact, nowadays we're doing a modified FMX. So we do anterior PAs and we do bite wings. Why do we do anterior PAs before we do orthodontics?
With bone level. Look at the bone
Bone
level.
level.
Orientation?
What's going to happen to teeth when we move them? Every tooth that I move orthodontically is going to have some root resorption. Every one. Except maybe the second molars may not have too much root resorption. But every one, and usually, you know, it's a ½ millimeter or a millimeter over 2 years. And it's not a big deal, it doesn't affect the longevity of the tooth. But I need to document where we start so that I can follow that during treatment. Because some people have really severe root resorption during orthodontic treatment. They could lose half the root. Or even some people have actually lost the whole tooth because of root resorption. So we monitor that. We have to know where we're starting. The bone levels are another good idea. We got to see the perio situation. Orthodontists cannot move teeth through inflamed tissue. So if you got gingivitis, you got periodontal disease, the answer is no orthodontics. So you have to be clean before you do orthodontics. So we're also checking for caries, of course. Can't treat orthodontic patients unless all the caries are completely taken care of. Imagine putting bands on teeth right here as part of the braces, and you put the band on over some decay, right? And then you can't see it anymore radiographically because the band is on there. It's metal. So you can't see the progression of the decay as time goes by. So you can't put bands on teeth that have decay. So looking for all the normal things, pathology too in radiographs. We do occlusal x-rays. What do you think about on this patient? You know, there's some crowding, right? So can I move teeth forward? How am I going to get rid of that crowding? Can I move teeth forward to make spaces so I can align the teeth?
Remove teeth.
I mean, I don't have much bone out here, do I? So it's hard to move teeth into air. So in cases like this, sometimes we extract a couple teeth and move the lower teeth back. over the top of the dome. See, so we do occlusal X-rays to evaluate where the teeth are in relationship to the base of the bone. And we're going to look at the joints. We're going to look in the sinuses. We're going to look for pathology and root parallelism. I'm going to make sure all the roots are roughly parallel. Okay, and then nowadays we're doing 3D a lot, right, with cone beam CT. So some of these other X-rays we don't do quite as much because we can look at the 3D volume and cut it any way we want. And so every patient in our clinic gets a cone beam CT nowadays. The ortho study models, of course, why do you think we have these all nice and trimmed with certain angles here? And it's completely trimmed back so you can see the full extent of the gingiva all around the teeth. And they're polished.
Presentation.
Why do we do that?
Presentation.
Presentation, absolutely. Number one, it makes me feel good to look at my case and look at that thing and see how nice it looks, how the models are, the detail is present. You can see everything about the patient right on those casts. So it looks good to me, but it also looks good to my patient's mom, right? So I'm going to show this to mom and dad someday. And I don't want a rough trimmed cast with broken teeth, something that does not look professional. So my patient's going to see this. Maybe someday a lawyer is going to see this, maybe a jury, maybe another colleague of mine is going to see it. They're going to see these casts, so they have to look nice. Okay? Other people are going to see it, not just the orthodontist. So we do it to have a good record of how the teeth are outside the mouth. But we also do some other space analysis and some symmetry analysis. I mean, if you get some real asymmetric cases going on, you can measure all the numbers out and you can quantify it in your mind. You guys don't have to learn all of this about how to analyze the symmetry of the case, but just understand that we're trying to look for symmetry and understand how we can make it more symmetric. This one you need to know. So you need to know this definition called ALD, because orthodontists talk about this all the time. We talk about ALD, arch length discrepancy. So it's just how much crowding is there on the case and how much spacing do you have, or how much spacing. So look at this case. The space available for this tooth that's blocked out on the x-ray is only about 3 millimeters. So the space between this tooth and this one, and this has to fit in that space, right? There's no more crowding anywhere else in the arch, but this tooth has to fit in a 3 millimeter space. But what's the width of that tooth? The width of the tooth is 7. It has to fit in a 3 millimeter space. So my ALD is minus 4 millimeters. Does that make sense? Arch length discrepancy. Anytime it says minus, that means there's crowding. And if it's just positive, that means there's spacing. So I could have positive ALD, or I could have negative ALD, and mostly I have negative ALD. So if I'm talking to another orthodontist, and I say this lower arch has minus 5 millimeters of ALD, immediately that orthodontist is thinking about a crowded case of a lower incisor, right? It's pretty easy to communicate. So maybe you guys, if you're working for an orthodontist or you're working for a dentist, you may run across this term. Especially on boards, you might run across it. It's called ALD, arch length discrepancy, and just the amount of crowd interspacing. Remember, positive is spacing, negative is crowd. Okay, so there's something else that we do called TSD, tooth size discrepancy. Which teeth are wider? The upper teeth, are they wider than the lower teeth, or are the lower teeth wider than the upper teeth?
Upper.
So how do you know that? the upper teeth have to be wider
They're on the outside.
Was bigger than you.
because there's overjet, right? All the way back, the upper teeth are always wider than the bottom teeth. So the bottom teeth have to be smaller. What if the ratio was 1:1? So I add all these things up, maybe it comes out to be 100. And this, if I added all these together for a patient, it came out to be 100. So they're equal widths of teeth. So when the patient bites together, what's going to happen?
They're not gonna close.
There's just going to be end to end on all the incisors, right? And I'll never be able to make the teeth fit together as an orthodontist because the widths of the teeth are not in the proper ratio. Now you don't have to memorize the ratio, but remember that the lower teeth have to be smaller, and an orthodontist is going to memorize what the ratio is. And if that ratio is incorrect, sometimes the orthodontist, like if these lower teeth are too wide, sometimes we'll slenderize the lower incisors, make them narrower, so that the ratio is correct, so we'll have proper overbite and overjet. Okay, so you guys are way too serious right now. This might be a little bit, you got the ALD concept, right?
Yeah.
TSD, you kind of get the feeling that you got to have the right ratio of the widths of the upper teeth to the lower teeth. And the upper teeth have to be wider. And if the ratio is wrong by genetics, right, I have to change the shape of teeth to match the correct ratio to get proper overbite and overbite. Okay, so sometimes we'll slenderize here. Or we could, like if it's a peg lateral or something, we could open space for a normal size lateral and do a crown or something like that to make the width correct. So remember that if the ratio's wrong, the orthodontist will never be able to make the teeth fit together properly. Okay? And it happens quite frequently that the ratio is not ideal. So we either have to remove some tooth structure, or we have to add, or sometimes we have to add down here. Make the lower front teeth wider or something like that. Okay, so ALD, TSD are kind of important ideas. We look at photographs. Has a nice, these are not great, not projecting well. Patient's not really red like this. But it's a good visual record of where the patient started at T1. You can see the profile, so you can get a good idea about the E-plane kind of thing. Smile line. We're going to talk about some characteristics today of the smile. And these are all recorded in T1. Like we even look at the chin, how wrinkled the chin is, how active the mentalis strain is. So we'll look at that in a little bit more detail in a bit. So chief complaint is the most important thing. I can put all the teeth together perfectly and have a beautiful occlusion. And if I don't really know what the reason the patient's in the chair, I might miss that real reason why they're there. They might be in there because they have a wrinkled chin, right? And I straighten the teeth and I leave a wrinkled chin, and then they're like, well, you didn't do what I wanted you to do. Right? So you have to know why the patient comes in to your office. You can't just assume they just want straight teeth, okay? Because different people have different ideas about why they're going to see the orthodontist. Somebody may have pain, may have joint pain, and that's the reason they're going to the orthodontist. Or, yeah, I don't know. It could be a lot of things. So it's very important to know why the patient comes to see you. And then do medical history, dental history, just like everybody else. And then we're going to try and determine facial type. We had this a little bit already in the last lecture. But remember the really long faces, skinny, those are called dolichofacial patients. Remember their GOGN to SN was really big, bigger than the norm. And brachies, the GOGN to SN was smaller than the norm. And they have wide faces, short vertically, wide horizontally. So hopefully all of you guys look beautiful, you're probably just normal mesofacial people. But there may be a few dolicos, a few brachies here. And those are beautiful too. Hope I got out of that. So what is this?
Prognath.
What kind of... Somebody said dolly? And this one would be more average probably. But you get the idea. Just by looking at the mandibular plane angle, or the angle of the mandible, you can kind of get a feel for the face type. Why do I care whether my patient fits in this category, this one, or this one?
Different arch.
Okay, so I'll never extract teeth on a brachyfacial patient, and I often will on a dolichofacial patient. So there's some differences in treatment planning. Even though the teeth are fitting about the same, I'm going to do things differently in different types of faces. But you're not responsible for, so you don't have to memorize that. Just realize that we, as orthodontists, want to know the shape of the face, because that's going to dictate some tweaks to our treatment plan. Okay, so... Okay.
Something strange in your neighborhood. Who you gonna call?
I'd cut the tape right here. You get the difference here. A little bit meso or brachy and a little dolicho. Okay. So we have some of our ghosts that are good sports and able to help us with this part of the process. What about facial symmetry? And, you know, the first thing we're going to do is we're going to look left and right, right? We're going to try and see if the patient is really asymmetric or not. What would happen like in hemifacial microsomia? Have you guys been through that word yet? It's like the joint and the mandible doesn't develop on one side, and so the occlusal plane's canted, it's really small on this side. So we're looking for severe asymmetry, because asymmetric faces are going to end up going to the craniofacial team for analysis. Okay, but what about these faces? Do they need to go to the craniofacial team? And none of you guys here have faces that are really weird. Well, maybe a couple of you. Okay, so a little bit of asymmetry is good, right? But a lot of asymmetry is going to go be evaluated for other craniofacial problems. Okay, so it's the first thing we do. We're going to look at the face and we're going to make a determination as to whether it's really out of balance or if it's normally out of balance. You guys are all normally out of balance. Nobody here is perfectly symmetric, because if you were, you would look like this. And you really would not look good if you were perfectly symmetric. So, when you're talking to mom, you never talk about perfectly symmetric being ideal. Perfectly symmetric is not ideal, believe me. Okay, profile. We talked about the E-plane, right? We connected tip of the nose to the chin. We're going to look at how the lips relate to that E-plane, right? Okay, so I don't think I told you a norm for that, but suppose this kid is like a Caucasian norm, which is a little bit behind the E-plane. How about the African American kid? If you drew the lips are ahead of here, right? Both of these are normal profiles. Okay? It's just that the Caucasian wouldn't look good that way, or an African American wouldn't look good this way. So different races, or however you want to split people up, I don't like to call them races, because we're all the human race, right? But however you want to split it up, different heritage type situations, the face is normal in different, from different areas of the world. Here's a Chinese guy, right? Really strong mandible, which you don't see in some of the other faces. But they're all normal. The orthodontist has to understand that people with different origins, different geographic origins, are going to have different aesthetic demands on their face, okay? So I'm not going to make my African American kids look like my Caucasian kids, unless they specifically come to me and I'm saying, hey, I really want to look concave in my profile, and for this reason, that reason, you know, I don't like the way I look, and I might change it. But normally, this guy's family all looks like that. This guy's family all looks like that. Okay, so we usually want to fit in with what mom and dad look like. Okay, so you get it. There's variation out there in aesthetics of the face, and that's okay.
The most well-known example of the frog's maligned reputation is the tale of the prince trapped in a frog's body.
So look
who
at the
needed
profile
princess's
now.
kiss to set him free.
So let's age it out a bit.
In 16th century England,
I wish you could see this from the side, but what happens with age is that your nose and your chin continue to grow. So your profile becomes more, no matter what race you're from, your nose is going to continue to grow, your chin is going to continue to grow. Like, if you look at this from the side, you see a real concave profile. But you didn't see that when she was a younger person. It was a pretty nice straight relationship to the E-plane. So the take-home point is that what happens as you get older, you start losing your, the lips tend to fall back, the nose and chin tend to keep growing. So what if I make my young patients look like they have concave profiles? Then when these girls reach age 50, they're going to look like they're 50, right? Which is older, more concave. So sometimes I'll err with my patients, especially the girls. I'm going to leave their lips a little bit more full so that when they're 50, they look like they're 20, okay? With their profile. So, you know, there's a lot of thinking in orthodontics. We want to think ahead and think what the patient's going to look like in the future, and then try to err on the side that makes people look a little bit better down the road, okay? So, profile is important. Here's a bunch of presidents all in a line here. I went down that data, whoever it was. Anyhow, all these presidents drove right by me, so I get to wait it out. But I didn't see them take. This was like in Time magazine, but it shows all their profiles. All these Caucasian old men with concave profiles. Even the women have concave profiles. So remember, this was the E-plane, and this is a normal relationship where both lips touch the E-plane for Caucasians. Hispanics or African American are going to be, or even Asian, are going to be a little bit more full. Here's a way you can test this in the clinic, right? Just use a mouth mirror, put it up. If you can't touch the nose and chin, then you know you have full lips, right? Or a convex profile. And you can see the concave profile there. So memorize this. I don't think this is in your notes. Is this in your notes? Did you get this 0 plus or minus 2? So you got it today. The normal relationship is 0. That means if I measure from the lower lip to the E-plane, it's 0 millimeters for Caucasians. Plus or minus 2. So if it's like 3 millimeters in front of the E-plane, we're going to call that convex. If it's 3 behind the E-plane, kind of like this one is, we're going to call that a concave profile. So remember, the older you get, the more concave your profile gets. So your orthodontist is probably going to leave you a little bit full when you're young, so that when you get older, you'll start to look normal. Smile fullness. What's the big deal here?
Seeing more teeth.
Which one do you like better? Top, bottom. Top, bottom. Actually both not too bad, but this one, look how the hard tissue smile, or the teeth, fill up the whole soft tissue smile. Right? Here you have a little bit more, you can see a little bit dark triangles in the corner of the mouth. It's not bad, it doesn't look horrible, but if it's possible, the orthodontist likes to err on this side of filling up the whole soft tissue lips with teeth. Okay, so I actually don't think either one of these look bad. They have great incisors, great incisaless display. It's just this one kind of stuck those first premolars a little bit farther wider so that you see them when the patient smiles. So I don't know which one you guys like better, but we try to go this way if we can. So our ghosts have a few, I think it looks fine. I'm not going to complain about them. How about the gingival display? Which one of these looks about the best to you?
3.
4. 3 or 4.
Maybe 4.
3.
That's funny. You guys say 3 or 4, most of you. But this is about what you want to do for a little 9-year-old kid, 10-year-old kid in your practice. You'd like to have them have a couple millimeters of gingival display. What's going to happen to this over time? So if you start this way, you're going to work your way this way down until you're older, right? And by the time you get to age 50 in Caucasian males, sometimes you don't even see the incisors when they smile. So this upper lip tends to relax and come down. So which one looks older? Does this look older?
Yeah.
This,
Oh, yeah.
this one, I don't think any of us want to be there, but it looks older to have less teeth showing. So sometimes we err a little bit over here, and maybe a little bit like this in younger patients, so that when they're 50, they look more like this or this. Okay? So we're looking at how much gingival display, and so what's your answer if I ask you on this, about this on a quiz? You're going to say 1 to 2 millimeters of gingiva is ideal. Okay? And less than that, less gingival display looks older.
Wait, how you do that then?
Just measure
How
this.
you? Wait,
Like from the,
no, besides that, how you?
How do you change that?
Yeah, how you pull the teeth down and keep the smile the same place?
I can intrude teeth,
Yeah.
or I can extrude teeth.
Well, wouldn't that be like...
Or if it's like
Cut
this,
down.
what am I going to do?
You cut them down.
We're going to do a maxillary surgery where they take out a couple millimeters of bone and move the whole thing out.
Wow.
Someone let it
Why
do.
is that just aesthetically, like, only for that?
Yeah, some people it's really not very aesthetic. Yeah.
Some people
There
are
may be
medicine.
other reasons
They
that
can
we're also
throw it.
doing the surgery, but if we're in there doing surgery, then we want to try to get the gingival display back to normal. So you can do what we call a maxillary impaction. So remove a little bone, you make an incision up here, remove a little thickness of bone, and just screw the maxilla back into position.
How painful is that for the patient? Like, how long is the recovery for something like that?
For this,
Yeah, for the bone.
for surgery in the upper jaw, so the pain is going to be the worst the first day afterwards, and they have pain medication for you, so you're probably not going to feel too much pain, right? And
It's a
then
healing process.
there's going to be 6 months where you have soft tissue swelling, a couple weeks of bruising probably, but the pain is under control because they have great opioids and stuff like that that you can take. So, our patients don't usually worry about the pain, but it does take a while for the face for the swelling in the face to go through. Okay, so 1 to 2 millimeters is the answer to the question. Is ideal. So you can see that some people, it'd probably be good to do surgery just to fix the gingival display, right? I mean, if you had this, which some people do, it looks a lot better after the surgery. It's not perfect yet, but she has really small teeth, but it looks better here.
What if they do like lip fillers?
Lip fillers, that might help a little bit here. Yeah, she doesn't look like she has much in the upper lips. Yeah. So Botox and other plastic surgery procedures could also be used to help. Okay, so they're looking pretty good. So then we're going to check out midlines, right? So everybody knows, all your patients know that there's a midline situation. So you can't really finish with the lower teeth shifted off to one side or another. So try to get the upper and lower midlines on. When it comes to being centered in the face, like this, most patients can't tell if they're off a millimeter from the center of the face. So if you have both midlines, dental midlines that are coincident, but they're off to one side, it's usually not a big deal, unless it's more than like 2 millimeters. Okay, at 2 millimeters, everybody notices that your midlines are shifted. So what's my goal with the midline? I want them coincident, and I want them lined up, not with the nose, because the nose can be pushed over to one side, but I want them lined up with the center of this philtrum. The center of the soft tissue smile is right where I want that upper midline to be. And then the lower dental midline will be coincident with this. So I could wave my magic wand. I would line up my hard tissue smile with my soft lips smile. So I want the symmetry the same here. It's not dependent on where the nose is, okay? Because the nose can be, where the noses go. They're all over the place. And the chin could be off to one side or the other. But whatever the asymmetry here, I don't want to make the teeth shift over to the nose asymmetry. But I want the teeth in the center of the lips. The center of Cupid's bow. Okay? So all of these people are all lined up nicely. Okay, so PSR, instead of recording every pocket depth, we just do a screening exam. So have you guys had PSR? Have you learned that yet? You just divide the mouth into sextants, and then you give them a score from 1 to 4 in each sextant. So anything more than a 2, you're going to refer back to hygiene or to a periodontist to have further work done. So it's just a screening exam, okay? Instead of recording pocket depths for everything, we record the worst score. So if there's like a 4 millimeter pocket, or a 6 millimeter pocket here, and everything else is perfect, then that's going to get the score of a 4 in that sextant, and it's going to be referred out to a periodontist for evaluation. Okay, so the worst thing in the patient's mouth is referred out. Okay, so anyhow, we're concerned. Why do we do this? Why do we care about the gingiva and the periodontium?
Because we're altering it.
The principle is the orthodontist should not move teeth through inflammation. Okay, because it's going to result in more bone loss. Okay, so no inflammation, then we can do orthodontics. Caries, yeah, well, all dentists have to deal with that. Why do I record like decalcification on teeth before treatment? So I'm going to record that. I'm going to draw a picture in the chart so I know where that is because
We do not mount brackets fingers.
So that when you take them off, they don't think that it was your fault.
Because some people, you can see right where the brackets were, right? So the brackets protected the tooth, but the patient was not brushing, so you have all this decalcification. So yeah, if you end up in this situation, you want to be able to go back and say, okay, but this was there before treatment, or whatever was there before, and then now this is the deal that we got to deal with now. So, or maybe this is how the case looks after treatment, and it's the same as before treatment, and then the patient might be worried, saying, oh, you caused this, right? As part of the braces, but anyhow, so we record where all the decalcification is on the teeth, in addition to the caries. So why do we care about this? Tonsils. It's all about airway, right? Is the patient going to be able to breathe normally through their nose, or are they breathing through their mouth? And this can be one reason why the patient has to open their mouth to breathe, because the tonsils may be preventing nasal breathing. So the problem is, if the patient opens their mouth to breathe, then the teeth erupt because they're not touching, and the upper teeth collapse because there's no tongue up in the top of the palate. And so you get crossbites and open mandibular planes, long narrow faces. So this can change the morphology of your face if you're breathing through your mouth when you should be breathing through your nose. So we're going to do an airway analysis. This is part of it. We want to know the size of the tonsils, especially in the younger kids that we're working on. Okay, and this, you see this all over the internet, people talking about TMD, right? All kinds of migraines, sensitivity to light, whatever, all these jaw problems, clicking, popping. There's all kinds of symptoms associated with joint problems, okay? So you might see this, or you might see a picture like this, people describing issues with the joint. So as an orthodontist, we're going to evaluate all those pops and clicks and pain before we start treatment. What do you think? Do you think orthodontists cause joint problems, or do you think the patient would have got those problems anyhow?
Maybe it's not done correctly.
Yeah? That's always a safe answer. If you don't build the house correctly, yeah, it's going to fall over. If you look at statistics, so I'm not making fun of you at all. Not really. I mean, a little bit, but. Okay, so if you look statistically, if you have two groups of kids, same age, that some have braces, some don't have braces, they tend to develop joint symptoms at the same rate. So, but I think that sometimes with orthodontics you can stress the muscles around the joint. So I think that there are some transient things that orthodontists can do to cause some temporary symptoms. But in general, the answer to the question, like if you're taking a board exam, you would say that there's no proven relationship between orthodontics, moving the teeth, and joint problems. Because people in the same age group who don't have braces develop problems with their joints at the same rate. Okay, but still, I'm going to record all the patient's symptoms at the beginning to see if they're changing, and I want to be responsive. If the patient is having increased symptoms in the joint, then I'm going to slow down treatment, or I may even discontinue treatment and let things settle down and then pick up treatment a year later or something like that, okay? So there's nothing here you have to memorize. So I don't want you to remember A, B, C, D, E, F, none of that. Don't draw that out for me. Just remember that the orthodontist is going to evaluate the joints before he puts brackets on this. You have a question?
I was going to ask, what are some of the major root causes of TMD?
The standard answer to that question is that it's multifactorial. So trauma is number one. You could get hit on the jaw and displace a disc. It could be just muscle imbalances. It could be degeneration in the joint, like arthritis, and arthrosis, things like that, bony changes. could be genetics. You could have weak ligaments that allow the disc to slip out of position. There's a lot of different questions that could happen. And rubber bands and things like that could cause some temporary changes in symptoms.
If you move your teeth too quickly, can that cause like TMJ issues?
I guess what I'm trying to tell you is that, yeah, I think any force that you apply to that joint can either accelerate or exacerbate the symptoms. But it's probably not creating a serious, irreversible problem. That if you just remove the rubber bands, then the symptoms go away. Does that make sense? So we're not causing blunt force trauma to the joint or something like that. Sometimes these joints just have idiopathic resorption. So the condyle itself will just resorb even without any orthodontic treatment. So there's many endocrine problems, issues. I'm not doing a very good job listing all the problems, but it's multifactorial. Okay, so I care about this as an orthodontist. So when is the time that you got to get the thumb out of the mouth?
Teeth.
Somebody said 6? 7? 1 year? So when do the upper and lower permanent incisors erupt?
5 to 6.
6, 5 to 6. So 6, I want the thumb out before those incisors erupt. Okay, so let's talk about my daughter. When did she get the thumb out?
Never had it.
Never had the thumb, right? And the pacifier? That was 2 weeks, and then it was gone, long gone. Okay, so I didn't want anything between the teeth. So that would be ideal. It's not always possible, but as long as there's something applying pressure to the teeth, you're going to get this open bite. And if you allow this to persist into the permanent dentition, then the bone that is supposed to grow as these teeth erupt won't grow. So you're going to have a bony defect up here as a result of the thumb sucking habit. So, age 6 is going to be my answer for the quiz question. If I give you a quiz question on this, you absolutely have to have the tongue out of there before the permanent incisors erupt, which we'll just say is age 6. 5, 6 is probably more correct. But the general principle is try and keep the thumb out of the mouth as early as possible so that the teeth can develop naturally, okay? All right. So it's not just thumb sucking that's a problem. If this patient is like a Division 1 patient with the buck teeth, well, the lower lip gets trapped back there, and if the patient sucks on that lower lip, that pressure is just going to push the teeth farther forward. So lip sucking, thumb sucking, finger sucking, any of these things that you do with your mouth is going to influence the position of the teeth. This mentalis strain is going to influence the position of the lower incisors. This is the mentalis muscle that has its origin in the lip and inserts in the bone down here. So when you constrict that muscle, it pulls that muscle against the lower teeth. It's going to move the teeth around. So I'm trying to think of a principle. Anytime the muscles are acting against the teeth, they're going to move the teeth, just like the orthodontist is doing it. Okay, so we want to know that. We're going to do all the regular things. Count the teeth, midline, OBOJ spaces. So part of our exam is to document all the cross bites and so forth. But there's really nothing there to memorize. It's just a normal dental evaluation. And then when we get all done with all of our evaluation, we come up with a summary statement. So it goes like this. We're going to list this first. We're going to say mesofacial. And we're going to say class 2 malocclusion, or whatever it is, 3. And then we're going to talk about skeletal. So how am I going to tell about skeletal problems?
X-rays?
SNA, SNB, right? And dental, and then aesthetics like lower lip to E-plane. And once I know that about a patient, and if I include like ALD, crowding, OBOJ, once I know that little bit of information about a patient, I basically know what kind of treatment plan I want to do for the patient. So I don't want you to memorize this list, but I want you to know this word. The orthodontist is going to come up with a summary description that summarizes all of the clinical exam in just a few words, a few points. It's like bullet points. And I can get on the phone and talk to a colleague and just list off most of these factors, and pretty soon we can talk about the case without ever seeing the patient or without ever seeing an x-ray or a photograph, and we can have a logical conversation about what we're... Okay, so you get it? All of these things we talked about today are important parts of our summary description. So that's it for that lecture. Anybody need 5 minutes? So we'll come back at 5 after 2. Oh, wait. So this is George, right? But, you know, if I let my hair out,
I don't know. Trying something new? I just thought you did it.
Dang, come late. Oh, it's a good job.
That was cool.
Why did you just talk about how they're doing?
Plug how everything's going. We have any questions?
What kind of shoes is that?
I know they're just talking about integrating like the dentist with them.
That meeting didn't help me. Maybe on the quiz.
It was because
I wasn't ready.
Oh, you're gonna blame it on the meeting?
No, I'm for real. Because I really didn't get to review it. It was just like, there was nothing to really talk about. Other than Jessica. Jessica. Like,
So yeah, there's no
So I'm wearing sandals today, but somehow this wasn't even because of me. Like they just really wanted like you're kind of like in Texas and stuff. And also made that all out there.
finish hygiene, then you go to dental school.
I guess I wasn't surprised.
She didn't make
She
it
didn't make it
up.
up,
She
but
didn't
like
make
it was
story,
just,
but it wasn't like
it wasn't such a big deal like a moment.
yeah. Be old by the time I'm done.
Oh, but you know, you're probably like 18.
Okay. She used to?
Maybe I'm 16.
Oh, okay. I feel
No,
it.
but anyway, they so they bring
I couldn't
up
say
Jessica
But you're
like
going to
infection control
be,
center,
21
and
plus
then like
6.
they were like, you know,
You're going to be 27. Maybe
where it was fun. I was like, well, today I'm actually getting scheduled. I was
What is
like,
it?
because I just have class.
Oh, man. I don't know. I've thought about it.
Like I was like, I just have class, so I don't know what I was when I am clinic and it's down campus. And then they said like some words for
So, yeah, you want to do...
she was was telling us like she's a good argument. She's not very good. She's like sharp. That like thing, and that guy was like pulls it up on the policy because the old guy was like telling me like she used to read the handbook. So then this guy pulls up and in the handbook it says only in clinic and laboratory. So they were like on it. And like they were kind of not like coming at me because it wasn't like that. It was just like very like yeah. So they were like, you gotta read the handbook, you know. And then somebody else was like, well, the handbook, they read that at the beginning.
I'm just here for moral support.
I know they did, but this is in the new handbook. So now they have to edit it again.
Just like
Next they have to reword it.
just before and after.
So this you can.
Everything.
No, we're still not gonna be able to figure it out.
Well, at
They're probably
first,
gonna sound.
yeah, no, we
Dang,
about like
what's the
how
word?
we can integrate like dental students more. You know, just student bands. In office together.
Use that very much anymore. People don't like
It's gonna be funny.
It was the first time we
It's really hilarious because okay. I already know that they're gonna be like, okay. And this one.
talk to me every year. I'll give you
Good question. So, I'm radiology quiz. Yeah.
So it's like we have different radiology.
So,
That's what I don't get. It's like we're graded
won't be as
differently.
bad, but
Then
we're not going to be able to
they
get
don't consider it for the radios.
you can still get
It's
like
I guess it's different.
5
That's what I don't get.
total 5.
They used to have them all doing at the same time.
They can be straightforward.
Yeah, they were. And they were. I just got too mixed up with the numbers. 32 and 82. But is there any other opportunity to boost our grade as far as an extra?
I can totally see it. Yeah, we are.
I really thought you were in trouble.
You gotta go to hopping around. Maybe like, this
I don't usually give extra credits. So
Or not even extra credit, just like if you want to do this assignment.
if you can study ahead of time with me,
Rolling her life away.
We did a couple of
I heard you were like that. I just feel like that's my class.
have a lot of confidence.
I think she just I think she was thinking she was
I don't think so. I think she genuinely is a good person and like I think she has a lot of good confidence.
I wasn't sad. Oh, I would take advantage of it. I did a great job.
Thank you. I feel bad.
No, actually, which I wasn't asking for extra credit. Yes, and they were. I just got too mixed up. And now I'm like, I can't even. I'm gonna go talk to
You can still get an 80 when you're out.
I want us to look at my teeth. I want to get okay. Alright, so I was gonna go to the clinic on the highway, but I never had my things they could look at. Well, I know my mom.
that one was tricky.
I missed
Your tongue teeth.
I like that color.
Are you? Were you allowed to wear that color?
I think it's but it's only IDP students. It's only international. That we are different colors.
There's a small chance that at your age that they decide to do some surgery to move that lower jaw forward.
On your knee?
You're young enough.
Oh, I thought you were talking to me. I will say you can still get it. I'll tell you what. I think he's going to do? I think the final is going to be this quiz plus the next quiz plus the house. Why is he making us? Why is he saying like this is square? Said they were all fair.
Right when they find out who it is, and then that was like people decide that they don't want to actually do the program, like last minute, and it just makes them feel weird. Oh wow. Yeah, that would be nice. Are you for sure going to? Maybe.
Said for sure that
Okay.
Catalina's in charge of that, so if you know
I want to make a profile.
You don't think everyone else does that? I'm doing like bridge with bridge. Trying to decide. Need to talk to somebody at a bridge. Yeah. Maybe?
How many of you guys are doing bridge?
Right here.
Like 1, 2, 3, 4, 5. Bridges?
7. Maddie, raise your hand.
Why am I raising my hand? Oh. He's like, raise your hand.
I just want to see. And you guys all want to be Orthodox?
Yeah.
That's the right answer.
You do?
Okay. Maybe not.
I like the knowledge.
I like ortho.
Don't you want to work in forensics? Forensic, yeah?
I don't think it works with all cases.
There are some Orthodox that say they can do more skill than you do.
I think it messed up if it's like a serious case. You know, unless they're like for kids, I would just be like, oh, I'm sorry. I'm a baby. I'm not control this shit. I'm gonna have it. You know what I mean? My dad did practice my dad. Well, he's not an orthodox player who has certification, so when I and there were some kids that they don't feel liars, and I looked at first of all, you're in high school, you barely came to this point.
Okay, is this any better from back there? Can you guys hear me better?
We can hear it.
Can you guys hear me better? Better? Better. All right. So we're going to talk about ortho appliances, and I'm not going to talk much about removable. I want to talk about fixed appliances, mostly. So these are all contemporary fixed orthodontic appliances. So what's the difference here?
Color. Clarity.
You're right, clarity brackets. So that's cool. How do you know that? You just named it randomly and got the name right? That's good. So, single crystal aluminum oxide looks pretty good on teeth. It's like ceramic brackets, or you could have metal brackets. Or what's the difference between these metal brackets and these metal brackets?
H versus I bracket.
There's 2 wings here. Here there's only 1 wing. Look at these. They have little latches here. So this latch, you can pop it open and take the wire up and relatch it down over the top. So you can have colored ties. But they're all the same thing because they all have the same slot that accepts the arch wire, and we'll talk about that in a little bit more detail. So the first thing you notice about braces is that, at least first thing that I notice, is that each bracket is different. So if you put a straight wire into a contemporary set of brackets, then each tooth is going to be positioned differently in space. So the cuspid has a different position in space. The ribs tip more distal, so look at the angle of this slot. It's a lot different than the bicuspid. It's going to have more of an upright root. So each bracket is individualized for the tooth, so you can't mix them up. You're going to put the brackets on, you have to put the right bracket on the right tooth in the right position. Okay, so these are two wings. Sometimes we call them Siamese brackets, like twin brackets, Siamese twin brackets. These are single wing brackets. What's the advantage of having two wings?
Stability.
Stability, that's correct. So the farther I put these contact points apart,
More torsion.
the more positive control I have with the arch wire. I can control the rotation of the tooth better. And the closer these 2 points get together, the more difficult time I have to rotate the tooth with the arch wire. So this is more difficult. This is easier. Okay, but well, let's not talk about that. So this is how the first orthodontic appliances look like. They were a piece of wood that had carved into it little places where the teeth should be. All these little concave areas were carved in, and then they just put a gold wire through these little holes here and around the tooth, and they would cinch this down until the tooth got tipped back into contact with this wooden template. And hopefully that was a nice smooth dental arch. Do the same thing for the lower arch. So this is called the bandolette appliance. Is that in your notes? Bandolette? Okay, then Angle came up with a couple other ways to do it. He used the same principle here. Here he's got a band on these two teeth. This is like from the 1900s, early 1900s. And then he put a heavy labial arch wire onto these bands. And then he used the ligature wires, and he would cinch those down and just tip the teeth out until they touch that arch form. Okay, so this is the same principle. It's just with wires. Instead of a wooden template, you have a metal arch form, and you're just tipping all the teeth out to match that arch form. So there's no control of the teeth in 3 dimensions of space, right? It's just two-dimensionally, just tipping the crowns or tipping the upper crowns out until they match the wire. Okay, so it's called an E-arch. E stands for expansion arch. And all you can do with that is to tip teeth. Remember we had 6 types of tooth movement? You can only do tipping with this type of appliance. And the same with that wooden form. Okay, so that was not satisfactory to Angle, so he built this system. It's called the pin and tube system. There are vertical tubes and pins. And he soldered these pins, one pin on, exactly in the right place for each tooth, which is a real laborious process to get all these pins soldered in the right place on the arch wire. And then he could change the angle of the pin, so if he took the pin this way and slid it in, it would tip the rig the other way. Right? So he had 3-dimensional control. He tip the pin buckle and the root would go lingual. So he had 3-dimensional control. But the problem with this is that only 2 or 3 orthodontists ever did this, because it's just extremely time intensive to try and solder each pin on in the right place, and then do buccal lingual, mesial distal, changes for each of those little pins, and then to get them all to fit draw at the same time is very difficult to do. So, but the advantage is three-dimensional control of the teeth. Okay, so that was really hard to do. Nobody did it. So instead, Angle went to this vertical slot, dropped the arch wire in. So here you can see the arch wire just drop in from the occlusal. And he was using gold arch wires in those days. So they called this a ribbon arch. And the gold was really too flexible. And so instead of producing a nice smooth curve, it would be asymmetric when he got it done. Because the wire wasn't stiff enough. Didn't have stainless steel in those days, around 1910. But this is a step toward the modern appliance because it had a slot. So that wasn't working, so great. Tony Hawk used to be the latest and greatest. Okay, but this is what Angle said was the latest and greatest when he came up with the appliance that we use today, which is called the Edgewise appliance. Okay, so it's not the universal appliance or the latest and greatest appliance or some other word that I might have on the quiz. The answer to the quiz is edgewise. All orthodontists use edgewise brackets, unless you're using clear aligners. Okay? So you can have an edgewise bracket, which means that there's a slot that opens to the buckle, and you just slide the arch wire in, and oops. Oh, we're going to talk about BEG real quick too. Remember, BEG is a system that's in place. There's a couple guys in Australia that still do this today, BEG system. He didn't use any edgewise appliances, just used tubes and springs on round wires, and so he does a pretty good job. Three-dimensional positioning of the ribs with the BEG technique, but it's only done by a handful of guys in Australia. So nobody in the US uses the BEG system. Okay, here's edgewise. So if you look at a slot from the side, or a bracket from the side, you can see the slot here. And the idea is if you have a rectangular slot, and you put a rectangular wire in it, and then you bend the wire, you're going to change the position of the root. So we used to bend the wire this way, and insert it in here, and then the root would go that way, or we could bend it the other way, and the root would go this way, or the crown might go this way. Or we could twist the wire this way, and then the root would go mesial or distal. Does that make sense? I'll show you better illustrations of this. It doesn't work with a round wire. Put a round wire in here, it just rolls around. But edgewise is a rectangular slot with a rectangular wire. And you can do three-dimensional positioning of the teeth with that kind of system. So, can move teeth in all planes of space. That's the advantage of edgewise. And it's rectangular slot, rectangular wire. Okay, there's three orders of tooth movement we need to talk about real quick. First, second, and third order. So, first order, you're just tipping the crown buccolingual, something like that, or rotating the crown. Second order is mesial distal root tip, like on the upper central incisor. The third order is buccolingual root tip. Okay, so we'll talk about these in a little bit more detail. Here's first order. So if you put in an arch like this, it turns out this is upper arch, this is lower arch. The best positioning of the crowns buccolingually is that this lateral incisor is stepped in a little bit. Okay, sorry. So we used to have to make these little bends in the arch wire like that. They're called first order bends to move the crown a little bit to the lingual. So we made two first order bends just to move the crown a little bit to the lingual to make it look a little bit better aesthetically. Okay, so or here's another first order bend just to rotate that molar just a little bit. So in and out movements, so in to the arch form or out of the arch form, those are called first order bends or first order tooth movements. First order, you're just stepping the tooth buccal or lingual, or you're rotating the tooth. So here's how it used to be. First order bend, first order bend, first order bend, first order bend. And then you get the teeth aligned to where they should be. But I don't know if you've heard of it, but today we use a straight wire appliance where we don't do first order bends, but we still get the teeth, like this lateral incisor is inset compared to these two adjacent teeth. So how do we do that? Thickness of the base of the bracket. So this distance from here to here is thicker than over here. We just make this as wide as we want and set that tooth. So it's the shape of the bracket, the thickness of the bracket base that determines the in and out positioning of the teeth. Or if I want to rotate a tooth, I don't do the first order bend here anymore. Remember, I had to do this kind of thing. I had to do a first order bend to rotate that tooth a bit. Now I just make the base wide on the distal and normal on the mesial, so when you put a straight wire through that, it automatically rotates the tooth. So this is contemporary edgewise or straight wire appliance. This is what we do today. This is what Angle developed, which required wire bends to get first order tooth movements. Okay, so let's look at second order. Wait, we're still in first order. These are all first order bends. The wires look like this. And nowadays we just make this wider, thicker, and now we automatically inset that. Or we're going to make this wider back here, narrow over here, to rotate the wires. So here it is, wider, narrower, automatic rotation on the wires. So what is a first order tooth movement? It's in and out, or buccal lingual, and rotation.
So not up and down?
Up and down counts too. Although on board questions, it's buccal lingual and rotation. But actually up and down is also first order. Here's second order. So it used to be the Angle would make this kind of a bend on one side of the tooth and the opposite bend the other way, and that changes the plane of the wire, and it would tip the root to its proper position. So every tooth had a little different amount of second order tipping depending on how severe you made these bends. But today we don't do that. We use a straight wire appliance. It's just that the angle of the slot is changed relative to the long axis of the bracket. Right? So this is, instead of being straight through the bracket, it's offset so that automatically when you put a straight wire in, the root is tipped into the ideal position. Second order is mesial distal root tip. So this is a second order wire bend, and this is a second order tooth movement. So you can see second order built into this custom prescription, and there's not much second order bend in the first premolar. So the first premolar is upright, the canine root is tipped this way. So that's a second order tooth movement that's built into the shape of the bracket. So every tooth has a different amount of distal root tip. It's almost zero up here on the premolars, but the cuspid is pretty severe. So you saw the difference in the previous slide. So you can't mix up brackets in different teeth, upper and lower, because the roots will go in the wrong place. Okay. So all of these are second order bends that Angle used to have to make, change the angle and all those planes so the roots would get tipped distal. Now we put a straight wire in and the roots automatically go into the right place because the angle of the slot is different for every tooth. Okay. Let's talk about third order real quick. This is buccolingual root tip positioning. So here we had to twist the arch wire differently for every tooth to get the root to go buccal or lingual. Now we use a straight wire, and here is how we do that.
So this one is specifically for the root.
Buccolingual.
Not the roots.
Remember, second order was nasal distal?
Yeah.
Third order is buccolingual root.
And the first order, isn't it?
It's just
Buccolingual
tipping
too?
buccolingual.
Or only tipping?
Not moving the root. So, what happens if I, sorry.
Oh, so is it the wire or the bracket placement that's doing the work?
Yes. Well, all of the force for orthodontic tooth movement comes from the wire.
Okay.
But the question is, am I going to have to bend the wire, or can I use a straight wire? It used to be that we had to bend the wire to get the roots in the right place, but now it's the shape of the bracket that determines where the root's going to go. Is that very confusing?
No, I think it is.
Almost. So check this out. Some of these teeth, I want the roots to go buccal. Some I want to go lingual. So how can I control that? If you look at a bracket from the side, if I was to put a rectangular wire in here, which way would this root go?
Down.
It's going to go this way, right? What if I put, oh wait,
No, it will go to the front.
it'll go forward, sorry. I'm confusing everybody. Right, because this is going to be a hot spot, this is going to be hot, and the thing's going to rotate this way, right? So the other way, if I put a rectangular wire in, it's going to be pressure here and here.
Yeah.
So the root's going to go towards the linguals. So we changed this angle of the slot relative to the face of the tooth.
So basically they control the wire.
Yeah, the angle here controls the position of the root. And you just have to put a straight wire in nowadays. But we used to twist the wire every time we wanted to do one of these tooth movements. So every tooth had a twist, every tooth had second order bend, every tooth had a first order bend. So you had to put like 3 bends for every tooth in Angle's old edgewise system. But today we build all of those first, second, third order bends into the shape of the bracket. So we have what we call a straight wire bracket. Anyone confused on the straight wire?
I think it's more of following along with the notes. That's weird to me.
Not too weird.
So for that rectangular hole, you just angle it in a certain way, depending on how you want the root to. So like, because I noticed the first one's angled this way, and then the middle one's kind of angled downward.
They come custom made, right?
Prefabricated.
So the orthodontic supply company is going to make these brackets in a certain shape, and there's a prescription, right? And you choose from all the prescriptions that they supply, you choose the one that you think should apply to that particular patient.
Okay.
So some prescriptions might have this root very prominent, and some might have it the other way. Right? So it's a little bit more detailed than I think we need to go for this lecture today. But realize today we use a straight wire appliance, which means that we don't have to bend the arch wire very much. But the old edgewise appliances, you had to put 3 bends for every tooth in the arch wire to get it in the right position. But now the shape of the bracket dictates the position of the root. So we have it a lot better today. Somehow that's off my radar. Okay, so we got composites along the way, right? And we got a metal mesh on the bottom of the bracket. And so, this is how Angle's original appliance looked. He put a band on every tooth and then attached a bracket on it, and every bracket was the same except here on the lower they have different brackets for the narrow sides of the lower incisors. But the point is, we don't use bands anymore on front teeth. We just bond the bracket directly on the tooth, right? And we're at this stage now. We just bond that on with composite. There's a retentive mesh on the back side of the bracket, so you just fill that up with composite, etch the tooth, and bond it directly on there. So we have bonded systems today. You can still use bands in the back if you want. But nobody's putting bands all around all the front teeth. So here's another system you might see. These are lingual brackets. These brackets are cast out of gold to exactly match the shape of the lingual side of the teeth. So the problem is, well, there's several problems, but what's the big advantage for lingual braces? Aesthetics, but nowadays we have Invisalign. So this is kind of fallen behind. Not many orthodontists do lingual brackets. All these brackets had to be custom made, cast out of gold. It was a real pain. And orthodontists would charge 3 times their usual fee. So if braces were $6,000, it's going to be $18,000 to do this case if you're going to do it from the inside. And then the wire is right there, right on your tongue, cutting your tongue all the time. So the only advantage is that it looks better. But now we have Invisalign, so I don't think this is used very often at all. And then the other deal with aesthetics is that these are very aesthetic brackets nowadays. You can have tooth-colored brackets, ceramic brackets. You can still see that the patient's wearing ceramic brackets and braces, but it's not like in-your-face silver, right? So ceramic brackets, Invisalign, mean that we don't use lingual brackets very often. And the next step, of course, is the really bright blue contacts, right? That improves everything. So if the patient asks for colored braces, they're asking for this. Just colored ties around steel brackets. Kids like to put these different colors, Christmas colors or Halloween colors or school colors. Who knows what they want. You can get gold brackets, ceramic brackets, maybe this steel gold. So remember, this is slot, this is wing, this is base. Here you can see the retentive mesh that locks into the composite. Slot, wings, base, ABC. So brackets are quite complex. Usually we have space for 2 arch wires to go through the bracket, and then here's a headgear tube. There's a hook for rubber bands. So they get very complex, all different shapes. But what is the common denominator here for all of these brackets?
Slot wing bracket.
They're all edgewise. Edgewise.
Yes.
They all have a rectangular slot. Regardless of all the attachments, all of these little slots are all rectangular for a rectangular wire so that you can do straight wire orthodontics. Okay, so we get all of this in and out, varying the base of the bracket. Mesial-distal by changing the angle of the slot, and torque, or the twist in the arch wire, is developed by changing the angle of the slot relative to the base. So the shape of the bracket nowadays eliminates the need for first, second, third order bands. So here's straight wire. Just remember straight wire, and we get the answer right on the quiz. Ricketts had his own wires that he called triple control. Why did he call it triple control? Because first, second, third order bands are all taken care of. So straight wire appliance. And remember, the arch wire is what delivers the force. And usually we go round wires. And in the middle of treatment we're doing square wires, and at the end of treatment we're doing rectangular. Why is that?
To taper.
minor tipping. And
So if you have really crowded teeth and you try to put in a big rectangular wire, it would just be a huge amount of force. So we start with little tiny round wires that have very little friction, and they're able to straighten out the teeth approximately. And then why would I use rectangular at the end?
With the most amount
fine
of force.
tuning. Fine tuning.
Because I want to fill up the slot and have firm control over the expression of that prescription, right? So by the end of treatment, I want to have the roots in the right place, but at the beginning of treatment, I just want to start doing tipping and minor tooth movements that help to align the teeth. Okay, so the answer to one question on the quiz is the arch wire is the force producing part, and another part we make this progression, round to square to rectangular. We finish in rectangular, we start in very small round wires. So let's try this table. Here's intrusion, extrusion, tipping torque, bodily movement, and rotation. So if I want to intrude a tooth, remember up and down was a first order movement, right? So we'll just say first order, and I can do that with a round wire. Just up and down, no big deal. But let's talk about extrusion. That's the same thing, just the opposite direction. It's still first order, just going vertically, and I can do that with a round wire. How about tipping? I can move the crown buckle.
Second.
Second.
It's still first or second. I'm just tipping the crown buckle. It's probably first order. If I'm moving the root buckle or mesial distal, then that could be second order. But I can do those kind of movements with a round wire. How about these two? Let's do torque. What is torque? Moving the root tip while not moving the crown, right? So that's going to be a third order tooth movement, and that requires a rectangular wire. Bodily movement requires a rectangular wire. And rotation can be done with a round wire. So the more complicated types of tooth movement require full control of that bracket. Okay, so that's a good table. Here's just some common orthodontic appliances. This one's actually not very common anymore. But two wires, one on the lingual, one on the buccal, help control the tooth from both sides. It's called the labial lingual appliance. Has some advantages, but maybe in the mixed dentition it's helpful to have like a lingual holding arch at the same time you're doing wires out in front to rotate teeth. So it's called labial lingual. When you see that in the quiz, then I'm just asking about wires on the buccal and lingual to improve control of your teeth. Here's palate widening appliances. So there's several ways you can do it. I'm going to show you some pictures of a Haas and a Hyrax and a quad. So let's get to that real quick. That's not a great picture, but this is a Haas appliance. It's attached to the upper molars and bicuspids. And it's split acrylic with a jack screw. So the patient turns this screw every day and moves this acrylic apart. And so what's going to happen?
It's going to open the suture.
So remember the maxilla has two bones, right?
Yeah.
There's two maxillary bones. There's a mid-palatal suture. So we're going to move the two maxilla apart, open up that suture, make a space between the two maxillary bones, and the new bone will fill in there. after this expansion. So I can increase the transverse dimension of the maxilla using this. So this is a palate widening device. This one's called a Hyrax. So you turn the screw, this moves apart, the teeth move, and if you do it with heavy force, then you'll split the palatal suture and the two halves of the maxilla will move apart. So there's two rapid palate widening appliances. The Haas has the acrylic plates, and the Hyrax does not have acrylic plates. They both have a jack screw, and the purpose is rapid palatal expansion. Here's a device for slow palatal. Oh no, here's a case actually. Look at this crossbite back here. Crossbite in front, crowding, upper and lower crowding, crossbite back here. So let's do the palate widening. This is 1 month later.
Wow.
Okay, huge diastema. So now we can move these teeth together, bring the cuspids into the arch, and straighten things out. So here's a slow palate widening device. This is called a quad helix. It's a spring. So before you cement this, it's too wide. You have to push it together and cement it. So there's a spring that's trying to push the two maxillary bones apart. But it's a slow process. So it can take a year to work, whereas the rapid expansion takes about a month. Fixed retainers could look like this, 2 bands and a lingual wire. Or could be bonded on every tooth, a little flexible wire, sometimes a little gold chain. Let's see, here's a better example on the lower arch. Bonded on every tooth. That is a flexible wire so the teeth can do physiologic movement. And the big drawback is cleaning.
Cleaning, buddy.
So you can't get floss in there, can you? Floss threader.
Yeah.
So you guys can motivate the patients to do that, right? So it's difficult. Some patients cannot have this appliance because they don't take care of their gums. Okay, so if you see a patient in your practice as a dental hygienist where the gums are inflamed and you have a fixed appliance, fixed retainer, then probably they should have this removed, and a removable retainer should be made for the patient so they can take it out when they floss. Does that make sense? So this one prevents flossing unless you're creative with a floss threader, which many patients are going to have either a hard time getting it in there and working through it. And you have to do it for every contact. It's kind of a difficult process. Water pit? Yes. Full bonded and banded appliances. We already talked about those. We talked about ceramic brackets already. Nothing I have to say here. We talked about lingual braces, right?
Mm-hmm.
The only advantage is aesthetics, and there are better things out there now. So this is not used very much at all, but Invisalign's better, ceramic brackets are better. Here's a Holly retainer. It has acrylic on the lingual of the teeth, and then it has a wire, a labial bow with an adjustment loop. So this goes outside the teeth, this goes inside. This is what the patient sees when they smile. This wire going across the front of the teeth. But it prevents buccal movement of the teeth, prevents lingual. These little acrylic tabs prevent mesial distal movement. So this is a good retainer. There's some clasps back here for retention. Another Holly retainer. Crummy picture. Here's a retainer here. These are positioners. Do you have positioners in your notes? Sometimes the patient will say, hey, I'm getting married next week, I want the braces off, and you're not finished yet, right? So, yeah, you got to take the braces off for the wedding, for the photos. But you can use a positioner, to position the teeth without brackets. So you have the lab put these holes in the acrylic in ideal positions. It's actually not acrylic, it's a soft rubber material. So the holes are in the right place and the patient has to chew into this device 4 hours a day. Okay, but it can reposition the teeth even if you take the braces off too early. So sometimes you have to do it, life happens. Somebody's going to get married or somebody's going to want to go scuba diving or something and they don't want that in their mouth, so they're going to take the braces off early. And you can offer, or even Invisalign could be done after you take the brackets off too, right? So, question?
Yes, sir.
Why are you laughing?
For how long do you have to wear these retainers? Does it each case depend on each case? Or?
So, we're going to have a lecture next time on retention, so I'll go over that. But I tell my patients it's like glasses, you're going to wear it for the rest of your life. You're going to wear retainers for the rest of your life if you want your teeth to stay exactly where they were when we took the braces off. Otherwise, what's going to happen, what are you going to look like in 50 years? Is your face going to look different?
Yeah.
All right, and the muscles around your teeth are going to be changing in their tonicity. You're going to get more sagging of tissues and stuff. Well, there's different pressures on the teeth. They're going to move. So teeth are going to move over time unless you have some kind of retention. So I say lifetime retention, and usually that means once or twice a week at night when you're sleeping. Okay, if you do that once or twice a week at night when you're sleeping, that can usually hold your teeth for your whole life. So it's not quite like wearing glasses. Naturally.
What about like tuning them, or like do they change? Like bend them more or less over time, or is that fixed like, for the rest of the life?
If you leave your retainer out for several months, your teeth could move, and then sometimes you can use the retainer to move the teeth back into the right place, but sometimes it requires some other treatment like braces or Invisalign or something to get them back into their correct.
No, I mean like maintenance-wise for the retainers. Like, do you need to fix them, or
Do I have to adjust them?
yeah, adjust them?
Occasionally.
Occasionally. And just take them back to the old.
Yeah. At least they should be checked. So headgear has an outer bow here, and then there's an inner bow that's soldered to it that attaches to the upper molars. And this goes around behind the neck, and then there's an elastic strap that goes around the neck. So there's a force to pull the upper teeth to the distal, back in the face. So we don't use it as much as we used to. It's very effective because you're getting an elastic around the neck, pulling the teeth back. It's very effective, but nobody likes to wear that in public. And there's some kids that are playing. We've seen reports in the literature. The kid will pull this out of their friend's mouth and let it go, and then it goes and blinds the patient or something. Because there's two like prongs on the inside that go to the upper molars. So those prongs, they're spaced about right from your eyes. So nowadays we have breakaway straps. So if you pull this forward more than an inch, the straps are going to break away. So you can't actually have the rubber band effect where you let the thing go into the patient's eyes. But it has happened before. And so there's some issues with headgear. Patients don't like to wear it. So we try to find other ways to do it nowadays. Here's a reverse pull headgear. This is like a catcher's mask. Sometimes these 10-year-old boys, you can get them to wear this. You just tell them, this is catcher's mask, you gotta wear it. And it works really good. There's like a pad here on the forehead and a pad on the chin. And so the rubber bands here are going to the upper molars. So the force is to bring the upper teeth forward. So this is getting what kind of a malocclusion? 1, 2, 3. 3. Last 3. really good. You can advance the upper teeth a little bit and the upper jaw with the reverse pull headgear. So, regular headgear moves the teeth back in the face. Reverse pull headgear moves the upper teeth forward in the face. Functional appliances look like this. What they do is they reposition the mandible forward, and then they have all these shields, plastic shields that keep the muscles of the cheeks away from the teeth so you can move them easier. I'm not going to go into a whole lot of description of what they do, but you'll probably see your patients wearing some functional appliances. If they have big shields out here to keep muscles away from the teeth while you're working, it's called a functional appliance. I don't use them very often, but there are some orthodontists that like to use them. Another functional appliance I'm not going to talk about, but positioners, remember, it's like Invisalign tray. All the holes are in the right place, and the teeth might be a little crooked, but the patient chews into this soft acrylic 4 hours a day, and then the teeth will be displaced into their correct positions. So, positioner again. There's a little crossbite appliance. If you have one tooth in crossbite, you can make this kind of a thing, acrylic plate. With just a little spring underneath the acrylic. You can push that one tooth out of crossbite. Bad picture of it. Crozet appliance was big maybe 40, 50 years ago. It's a wire framework that snaps onto the teeth, but then it has all these attachments, accessory wires that can be used to move teeth. You can attach wires on the buccal or on the lingual. You can have hooks on this to hook to elastics on teeth or accessory springs. So, but this is a tooth-borne wire frame that you can do all the orthodontics with. Okay? Mostly tipping of teeth though. They're very good if the patient doesn't want to wear any kind of braces, but they're willing to wear this metal framework that just snaps on, and then at every appointment the orthodontist adjusts these attachments to push the teeth in different directions. Here's one in place. You can use these sweep arms to move the upper anterior teeth forward. Okay, let's get this chart down. So we have fixed appliances and removable appliances. So let's contrast them. Which one controls the teeth better?
Fixed.
So let's say fixed does a better job for controlling teeth in 3 dimensions in space. Which is the fastest treatment?
Fixed. What?
This is like 5 hours, and this is like 3 hours. This is fastest. This is slowest.
Oh. So you have more control?
Just use the words fastest and slowest.
Okay.
Instead of asterisks.
And the first one, fastest?
This is
slower?
better control, not as good control.
Okay.
So this is slower, faster.
Yeah.
What's the problem with removable appliances?
They come out.
Patient compliance.
Compliance. So the patient may not wear the appliance when you send them home with the appliance, and that takes time away from your treatment. Fixed appliance, if the braces are in there, the patient's locked in, and the force is going to be applied no matter what they call. So this has the best patient cooperation. I mean, least problems with patient cooperation. This has most problems with patient cooperation. So I don't know, my asterisks aren't helping us too much, but this is less patient cooperation, this is more patient cooperation.
Required.
So removable has more patient cooperation? No problem. Okay.
Maybe don't put any asterisks at all. Let's just say control is better with fixed, shorter, with fixed. Cooperation is much better with fixed appliances, and it's much poorer with removable appliances. And then, which can give me the best treatment results? Fixed. Which is the best for hygiene? Doesn't matter, either way you have to brush your teeth. Which is best for extraction treatment? Let's say fixed. Fixed is better. This is my last case. No, just kidding. So what are we doing? 2 weeks? Yeah.
Huh.